Welcome to the 6th Chronic Pain Learning event. Excuse me. We're going to talk about analgesics, the pros and cons, and ways of thinking about them, and then think about how we can discuss that with patients. But it's a really short talk that I've got because Kathana's brought a case presentation which fits in really well with it, because it's a patient who's on analgesics. So how have we got into the situation that we're in now? There's lots of Einstein quotes on the internet, and half of them he never said. But I don't really care because I really like this one. It's the difference between stupidity and genius is that genius has its limits. And so what happened with analgesia is that in 1985, the World Health Organization devised the World Health Organization, or the WHO, pain ladder. And you know, see there's a little hint on the top step there that this was actually developed for cancer pain. So until relatively recently, it was thought to be really dangerous to prescribe opiates, even to people with terminal cancer. And textbooks right up until the 1970s would say that you should never prescribe strong opiates for people with cancer because they become... oh, hi, Laura.
I was just going to say, Steve, I can't see anything. I don't know, are you sharing?
Oh, have you got the slides there? No?
No.
No?
I don't know, is it just me or can everybody else see?
I can see them, Steve.
All right.
I can see them.
Yeah, I can see them as well.
Oh, they might, if you hover over the Teams icon down on the bottom taskbar, then you might see another window.
I can see them.
No, can't see them. That's okay. I'll just listen.
Well, what I'll do is I'll share it the other way, so I'll stop sharing.
I can email Laura the slides so she can bring it up. I can do that while you're speaking, Steve.
Okay, great. Right.
Okay.
Yeah, can you do that for me as well, please? Thanks, hon.
Oh, who was wanting them as well?
Sorry, that was Becky Hunter.
Oh, right. Oh, right. Let's see. It does say. Let's see. Just I'll just see whether I can start it again. I'll just replace it and see whether that fixes it. Just take a wee second to upload again. So the World Health Organization analgesic ladder. First of all, it doesn't look like a ladder, does it? It looks like steps to me, and it was devised for cancer pain. Has that fixed the issue, Laura?
No, but Nicola's emailed me the slides, so I can see what we're referring to, so that's fine.
Okay, so this is slide 2, and so the reason that people were so worried about opiates was that in laboratory animals, they developed tolerance very quickly. So if you give rats a choice of morphine or something nice to eat in a cage, and they had to press a button either for food or for morphine, they just press the button for the morphine, and they would end up starving to death. And they would, then they would have no analgesia when they were doing painful things to them as well. So what they later realized was, of course, that these rats had been kept in a horrible cage without any natural environment, no friend rats, no play equipment, and so this situation actually only applies to rats that are kept in a bare cage with sort of social deprivation. And when you put rats in a rat playground with lots of friend rats, then they don't do this. But in any case, when the hospice movement was established in the 1960s, they discovered that giving patients opiates by the clock, sustained release opiates, and breakthrough analgesia controlled cancer pain really well, and they didn't develop tolerance or addiction. And so that was a great advance. And Cicely Saunders went to talk to the Royal Medical Society and was booed off the stage because everyone thought she was talking a lot of rubbish, and she had to invite the high Hegians to go along to the hospice and see what she was doing, and that the patients were actually much more comfortable and that they hadn't become addicted or tolerant. So the trouble is that we've ended up applying this to this model for cancer pain to acute pain and to chronic pain as well. And so the idea of the analgesic ladder is really simple, that you start off with a non-opioid like paracetamol or ibuprofen, plus or minus an adjuvant such as amitriptyline or an anti-epileptic. And then if you're not got pain under control or it's increasing, then you go on to a weak opioid, which would be codeine. Is really the only one that's in step 2 now, because tramadol's been promoted. And then you would carry on your non-opioid, your paracetamol or ibuprofen, and your adjuvant. And then if you've still got pain, then you would go up to step 3 and use a strong opioid. And at the same time as this was being introduced in the 1980s, there was the introduction of the sustained release opioids, which allowed you to give morphine or around the clock. So in 1990, so that's 5 years later, where's my slide gone? Sorry, I've gone to the wrong slide. I've got my slides in the wrong order. So this is slide 5 now for those who are looking at on the in 1990, Ron Melzack, who's a really big cheese and pain medicine, Melzack and Wall wrote a paper in the 1960s about the gate control theory of pain, and so is a really famous researcher. He wrote this paper for Scientific American called The Tragedy of Needless Pain, and what he said was that contrary to popular belief, morphine taken solely to control pain doesn't cause addiction, and then patients are being denied the human right of analgesia, and they're suffering unnecessary agony. And I read this actually in the 1990s, and I was really convinced by it, because he was talking about the difference between a pain patient who is trying to return to normal and an addict who's trying to escape from reality. And pain patients, they hate the side effects, and addicts are just taking the medication for the side effects. He cited some research papers. So unfortunately, the research papers were pretty poor quality. They were over a short period, and they were looking at quite small numbers of patients. So one was looking at about 40 patients with chronic pain, and I think 3 of them developed some problematic drug behaviour. But they didn't think it was a serious problem over the 12 weeks of the study. And the other paper that was quoted by NAP, the company that marketed MST and then oxycodone, was the Boston Burns Hospital, where Howard Jicks wrote a letter to the New England Journal of Medicine saying that he'd seen almost 5,000 patients go through the Boston Burns Hospital. They all had morphine, and only 3 of them developed addiction problems. And so his premise was that, in fact, it was more likely for the doctors who were working at the hospital to get addicted to drugs than the patients were. But of course, this was a letter about his experience, which was in no way a scientific study. So it was, just a very informal letter, but it was quoted by the drug companies for many years. So I'll just let Josie in. And so from there, we ended up with this promotion of analgesics. I don't know why I've managed to completely mix up the order of my slides. So this is slide 6 for those that are looking at the non-Teams version. So in conjunction with this promotion of opioids as being safe and effective, there was also quite a bit of campaigning, particularly from the American Pain Society, which was campaigning for pain as the 5th vital sign. And I was listening to a podcast, I think it was on Radiolab, and there was James Campbell, who had been in the president of the American Pain Society, said it came to me in the shower. I thought, the 5th vital sign, it's really vital that people look at pain as well. But of course, the other vital signs like your heart rate and your blood pressure and your breathing and your temperature, they're things that we can measure objectively, whereas pain is a subjective experience. And then there's the campaign to stop pain and to have pain recognised as a disease in its own right, which are all looking to promote the increased use of analgesics through the 1990s and the 2000s, and particularly the Veterans Medical Association in America really pushed this. For instance, they would say, if you ask the patient if they got pain, just check, are you sure? Do you not have some discomfort that we might need to give you something for? And so it was really, looking to eliminate all suffering. So the problems with that we all know is that there's been opioid epidemic in the United States, which is to some extent been replicated in other countries. In Australia, there was a lot of opioid prescribing and some really high doses, and it's not been quite so bad in the UK. So now we're going back to slide 3, I'm afraid. Sorry about that. So the simple analgesics, everybody will really know this, that paracetamol is safe as long as you don't take an overdose of it and doesn't really have any side effects. But unfortunately, there's a really big study looking at paracetamol for back pain showing no difference from placebo. It's when that systematic review and meta-analysis came out, there was a lot of disquiet. We can't even give paracetamol anymore. Non-steroidals are very effective for quite a lot of kinds of chronic pain, especially musculoskeletal pain, but they can have some dangers in long-term use of the gastrointestinal bleeding and renal failure and blood pressure and all these sorts of things. And then amitriptyline and the other tricyclic antidepressants, they can be effective, but again, they've got some side effects. And the introduction of duloxetine as an adjuvant, perhaps less side effects. I think quite a lot of patients find that it makes them feel quite nauseous, but certainly less dangerous in overdose. The trouble with the old antidepressants like amitriptyline and nortriptyline, if you take them in overdose, then they can cause cardiac arrhythmias and you end up in intensive care. So that's why they became a lot less popular for treating depression. So I think the other issue, as everyone will have come across, is that when you say to somebody, I might give you an antidepressant for your pain, then we have to really explain to the patient it's not for depression, and that it's hoping to modulate descending facilitation from the midbrain, which is perhaps how they work. Maybe they have other effects as well. So on to, I have really messed up these slides, sorry. So let's see. Yeah, I'll just stick with the order that I'm in and I'll look back at this recording with horror. So I think a useful way to talk to patients about analgesias, think about these sort of 5 A's. The analgesia, we're going to see whether something actually helps your pain. Is it going to make a significant difference to the level of pain that you're getting? And is that going to allow you to do more of what you want to do, more activity? Or we've got to look out for if there are any adverse effects or the side effects that are causing problems, like the drowsiness, confusion, difficulty with memory, the bowel problems that people get with opiates as well. And then affect is how you feel in yourself. So if you're feeling that you're knocked out, or you're feeling down or anxious because of your medication, then obviously that's something to take into account. And do your people that you're with, do they see you as being back to your old self, or are they worried about you? And then aberrant drug-related behaviour, where people can end up becoming dependent on medication, where they can develop tolerance and have to increase the dose, or become addicted and are taking the medication for things that it's not for helping with mood or with sleep, or to get high. And so I think that discussing these things with a patient before you start is a really useful way to go. And there's some really good resources on the Agency for Clinical Innovation website from New South Wales in Australia, which I'll show you at the end. So I often say to patients that, with addiction and dependency, the opioid analgesics, they're working on your endorphin receptors, and you're hitting the reward center in your brain. So there's a biological effect which is going to suppress your own endorphins, and it's going to set off the dopamine from the reward center. And so it's not a character problem that causes addiction. It's a neurobiological condition, and it's a lot more common than we think. So the NAP publicity was that it was less than 1%, but it's probably more like 1 in 4, 1 in 5 people that develop some problematic drug behavior and take more than they're prescribed, or take it for something else rather than for what it was prescribed for. And some surveys finding that there are more than 1 in 4 people in the population that have taken analgesics that weren't prescribed for them. So they've taken somebody else's analgesic medication. So we're back on to slide 7 now. So looking at the prescribing in the UK, this is a massive cohort study of almost 2 million people who were started on opioids without having a diagnosis of cancer. And I've put the link which you'll be able to access the paper. And so it was between 2006 and 2017, most people were prescribed the weak opioid, the codeine, and there was a 5-fold increase in codeine prescriptions over that 11-year period. There was a 7-fold increase in tramadol prescriptions, and in the early 2000s, there was a big spike in the number of tramadol-related deaths, which is what has ended up with it being promoted from step 2 to step 3 of the analgesic ladder, or steps. And then there was a 30-fold increase in oxycodone prescriptions. Now, of course, oxycodone is the one where there's been most concern about it in America, and Purdue is the parent company of NAP, have been massively fined for their promotion of oxycodone as safe, and effective. But really, it is heroin with an extra hydroxyl group. So it's exactly the same chemical structure as heroin with one extra hydroxyl. And one interesting historical fact is in the 19th century, when morphine was synthesized artificially rather than being extracted from opium, it became a big problem during the second half of the 19th century. And diamorphine or heroin was introduced by Bayer at the very end of the 19th century as the solution to the morphine addiction problem. In fact, that was why it's called heroin, as it was going to save the day from all these poor people that were addicted to morphine. So it just goes to show that the Einstein quote about the limits to genius and stupidity definitely are not something new. Almost 90% of our patients were initially started on a weak opioid, but there was actually 8.5% were started on a moderate opioid and 2% on a strong opioid. And the prescribing factors were really interesting, that they were using current gabapentinoids. They were older. They had more socioeconomic deprivation, and this was borne out in a study that we did back about 10 years ago, looking at opioid prescribing in Scotland, where we found that it was really strongly associated with socioeconomic deprivation, and it was prescribed for things like fibromyalgia, rheumatological conditions, and all the risk factors increased the likelihood of prescription. So the things we would look out for is a history of substance abuse or suicide or self-harm, alcohol abuse. They're factors that were actually associated with more prescribing. If people had major surgery, then it was more likely they would carry on taking their analgesics after their operation. And so that's something that really needs work to encourage people to reduce their opioids after surgery as they're healing up. And so around about 1 in 6 people became long-term opioid users after the first year of initiation, which is, a massive number if you're looking at almost 2 million people. Okay, and then the long-term use was associated with being older, social deprivation, fibromyalgia, the suicide, self-harm, excess alcohol, using gabapentinoids as well, and other psychotropics. And the higher the initial dose, then the more likely people were to carry on. So it's just a wee graph showing that, the codeine is the vast majority of prescriptions. I'm sorry about the colours on this, it's not very clear. But if we look out at the small box that they've taken out with this, the strong opioids in here, then the dihydrocodeine and the other strong opioids, then as things are introduced, they rocket up in prescription. And so things like the fentanyl patches and buprenorphine patches have been introduced more recently and are going up in popularity. So what people can worry about, I think, is opioid-related deaths. So this is a case crossover study, which was found that they're looking at, this is the Office of National Statistics death certificates of 1.75 million patients prescribed oral or transdermal opioids. So almost a million of them, so 58%, had linkage to the death certificate. And in that, there were 232 cases of opioid-related deaths. So that's only 0.02 of the 1 million patients, which is it's really reassuring. Sorry, I messed up my slides here. So 30% of the opioid-related deaths had not been prescribed an OMED more than 50 milligrams. So, and so the risks of opioid-related deaths increased significantly when gabapentinoids and some antidepressants were prescribed with the opioids. And I searched through the paper, but I couldn't find which antidepressants they were thinking about. But I was thinking the more sedative ones, and really interestingly, a quarter of the people who died with an opioid hadn't been prescribed it, so they were taking somebody else's. So drug-related deaths in Scotland are making a wee bit of an increase. Okay, so that is with all the drug-related deaths, and then heroin and morphine are down here. So, but also, codeine associated with death. So it's something to think about. But I think the much more important thing is the people that have near misses and the people that live on with side effects, which are we worry about effects on the bowel and the immune system and the hormones. So it reduces your testosterone, which gives you osteoporosis and increased risk of fractures. And it's but I think the most insidious thing, and the way I put it to patients, is that it affects your motivation and your enjoyment of life. So these medicines are working on your endorphin receptors, but they don't give you the same sort of joy as endorphins do, and so you can end up drifting through life and not really getting so much out of it, and the lack of motivation makes it very difficult to move on. So, the biggest risks are co-prescription between the opioids and the benzodiazepines. So obviously everybody knows that, and I think there's been some reduction in benzodiazepines, but there is quite a lot of street benzo floating about, I think especially in Lochaber. And then gabapentinoids and other drugs, they're sort of climbing steadily as well. Maybe slightly less prescribing of gabapentinoids in Highland than there is in some other parts of the Highland, other parts of Scotland. So it's not entirely safe, but are the opioids any use for chronic pain? And so there's some really interesting studies. This SPACE study was published, I think about 3 or 4 years ago, and it was a randomized trial of 240 patients who were either prescribed opioids or non-opioids for hip, knee and back pain. And they didn't find any significant difference in pain-related function over the 12 months of the study. And not any improvement in pain either. There's a really good review of opioids for low back pain by Richard Dale in the British Medical Journal from about 3 years ago. And I think the interesting thing there is that it refers to evidence that people who receive opioids for more than 7 days are twice as likely to remain disabled at 1 year. And I think we can really say to people with back pain, if you go on these strong medications for more than a week, then it's actually reducing your chances of ever getting better. And then looking at an observational study of primary care patients receiving opioids for low back pain, those receiving the opioids had worse pain. Now, that's not necessarily cause and effect, it might be correlation rather than causation, but they had poorer function, they had less self-efficacy, so they felt less confident in themselves. They had more catastrophizing, so more magnification and hopelessness and fear of pain, and depression after 6 months than those who didn't get the strong opioids. And it's interesting looking at the effects of opioids on the nervous system. This is a study from Irene Tracy looking at placebo. Irene Tracy is a very stern professor of neuroscience in Oxford, and she puts people in functional MRI scanners and then burns them with a laser to see what their pain experience is like. And in this study, she hooked them up to infusion of alfentanil, so it's a souped up version of fentanyl intravenously, and compared what happened when she gave them fentanyl with saline. So the tricky bit was that she didn't tell them that she was starting the fentanyl right from the beginning of the experiment. So they connected up the drip and started it running either fentanyl or saline, and she said, right, now we're going to burn you and see how much pain you've got. And so she hadn't told them that she was starting the infusion, saying we're doing a baseline, and you can see that there is a little bit of a reduction in the pain score with the alfentanil. So it goes from 6.5 down to 5.5 on a 10-point scale. And then she says to them, now we're going to start this really strong painkiller. It's massively more potent than morphine, really, really powerful stuff. But she didn't make any change to the infusion rate, just kept the same thing running. And you can see that there's a massive difference, and quite a bit more reduction in the pain. And all these areas, the dorsolateral prefrontal cortex, the anterior cingulate cortex, and the periaqueductal gray matter, where you produce your own endorphins and descending inhibition of pain, they were all active on the functional MRI scan. But then, even more trickily, she said, now we're going to stop the infusion, but she didn't. She just kept it running at the same rate, and we're going to check what's happened when the drugs have worn off. And you can see that when people thought they weren't getting any painkillers anymore, all of their pain relief went away. There's no difference between alfentanil and placebo. So the way we describe pain management to patients is really important, I think. We can sometimes give people nocebo suggestions, the opposite of placebo, that we say that, like there's lots of wear and tear there, there's lots of damage, and you've got to look out for your back and all these sorts of things. So perhaps that's it gives you a perspective on what are these analgesics actually useful for. And a really interesting study in France looked at people with acute back pain who came into emergency departments, and they compared paracetamol, ibuprofen, and morphine for their back pain. And if I was to ask the audience, which one do you fancy for your pain? Would you rather have step 1 of the analgesic ladder, or do you think step 3 would be better? You know what the answer is going to be. So, but when I asked a whole audience of GPs at a palliative care conference about this, they all went step 3. And in fact, the results were that there was no difference between paracetamol and morphine, that neither of them made any difference to the back pain, and ibuprofen was much more effective. So it's looking at what the analgesic is for rather than that sort of analgesic ladder sort of dogma. So assessing the risk, if you look at the SIGN guidelines, there's quite a bit about opioids, and unfortunately I was involved in writing the first version, which I wasn't entirely happy with, but it got published anyway, and it was going on about trying different opioids, rotating round, and was really quite sitting on the fence. There's not really good evidence, but it's worth trying them. But one thing we did find was that all of the things that you can assess risk with are not very accurate. And so if you look at the opioid risk tool, then if you have a history of substance misuse in the past, especially if you abuse prescribed drugs, or if you have a history of childhood trauma, or if you're in this sort of 16-45 age group, then and if you're male, then it's more likely you're going to develop addiction problems or aberrant drug-related use. But if people fill this in themselves, then they quite often don't mark their risk up. And so there was a study where they didn't even get their age right. So this really has to be, so taken with a bit of a pinch of salt, and it's probably better to talk about it as well. If we do this opioid risk tool with you, we can see that there's a possibility of you developing some problems, and we need to take that into account and make sure that we're not going to do something that's going to cause harm. So if we're thinking about how strong our opiates are, then that can be really quite confusing. So people who get started on something like a fentanyl patch, and you ask medical students or junior doctors about, how much morphine is that equivalent to, they often not really much of an idea. So using the drug calculator on the Glasgow Pain Data website can be really helpful there. You just put your drugs in and it gives you a morphine equivalent or oral morphine equivalent daily dose. So a 100 microgram fentanyl patch is equivalent to around about 300 milligrams of morphine a day. And I would often say to patients, if I've got somebody who's had a big operation, I might give them about 40 or 50 milligrams of morphine over the next 24 hours. I wouldn't give them 300 milligrams of morphine, that would be too much. And when patients are taking strong analgesics like that and they've still got their pain, then obviously it's not really having all that much effect. So I'm maybe going to skip over neuropathic pain. I talked about neuropathic pain before, but I'm running over time, and Kathana had brought a case study. But just to say that neuropathic pain isn't as common as people might think it is. It's maybe about 5% of chronic pain, and we can use the DN4 dual neuropathic on-catch questionnaire to get an idea of whether it's possibly neuropathic pain, but we really need to find a neurological abnormality to say it's more likely to be neuropathic pain. And then the medications are not entirely 100% effective. So your amitriptyline helps with maybe 1 in 3, 1 in 4 patients. Your gabapentin helps maybe 1 in 6, similarly with duloxetine, and your pregabalin number needed to treat is more like 1 in 8. And strong opioids, the number needed to treat is around about 4. So it's actually more effective than gabapentin. But in this paper by Finnerup in 2015, they didn't recommend opioids because of the risks. They put it into yeah. So I like this diagram by Mike Nicholas from Sydney. Sorry, I've not been telling you that I was advancing the slides, Becky, and okay there. So you can end up with this. This is the last time I use a PowerPoint suggestion for design because all the writing's too small in this now. But you end up with a sort of reduced activity, unhelpful beliefs, repeated treatment failures. So you try things and try something else, and you add things on. Use the analgesics, which affects your motivation and your affect, and you lose your job. And the end result is excessive suffering. So we don't want to end up there. What we want to do is to apply more pain management ideas earlier on. So I'll email out these resources. The Faculty of Pain Medicine's got really good information for patients and prescribers in the Opioids Aware resource. There's information about all different kinds of medication on the Highland Pain Info website, on the Medication for Pain page. The Brain Man Stops His Opioids is a wee cartoon from Hunter Valley in Australia, which talks about the evidence, and what we find is if people reduce their opioids and stop them, usually the pain is not any different, and there are a proportion of people whose pain is better. But importantly, there are some people whose pain does increase and they have a better quality of life on opioids. So I think that we have to remember to treat everybody as an individual. So we can't be totalitarian and tell everybody to reduce their opioids. Now, I was going to come back to reducing opioids in another talk because that's a whole other topic. Quite often I will show patients Crystal's story, which is from The Doctor Who Gave Up Drugs by Chris Van Tilliken from a few years ago. And it starts off with a lady who's hurt her back in the gym and ended up on codeine and tramadol and really suffering with lots of side effects and really disabled. And a 12-week course of coming off the drugs and getting back to activity is what actually makes her better rather than maintaining her disability. Now, there's quite a bit of variation in prescribing between different areas in Highland, and you can see them on the ISD website. From what DDD stands for is daily defined dose, which is 100 milligrams of morphine, which is quite a lot, I thought. So there's a variation from a low of around 50 milligrams of morphine a day up to 6 grams of morphine a day. Now, that was a special patient who skewed the data there. It was a patient who had palliative care and was getting lots of hydromorphine and other stuff. So we have to take these figures with more information about the actual situation.